My name is David McCarthy. I'm the Arizona coordinator for the Western Regional Alliance for Pediatric Emergency Management and work along with Dr. Marianne Gashi-Hill leading the EMSC focus group within RAPA. And with that, I'll pass it to her for introductions of our speaker today.
Okay, welcome everyone, and I'm really excited to introduce a true expert in the care of children with traumatic injury. Aaron Jensen is an associate professor of surgery at the University of California, San Francisco, and where he maintains a busy clinical practice in pediatric surgery. He also serves as the trauma medical director at UCSF, Benioff Children's Hospital in Oakland, definitely a busy trauma center. He also serves as a trauma domain co-lead at the EMS for Children Innovation and Improvement Center. He is active with the American College of Surgeons Committee on Trauma. He's the National Vice Chair for the Quality Pillar and the Trauma Quality Improvement Program, commonly known as TQIP. He's also serves in that capacity as Vice Chair for Pediatrics for Northern California. Dr. Jensen serves on the Board of Directors, the American Board of Surgery, Trauma, Burn, and Critical Care Board, and always seeking to have the highest quality standards for surgical critical care for practitioners, and obviously which benefits the patients that they serve. His research focus is on quality improvement in pediatric trauma care, and today he will be presenting Little Kids, Big Resuscitations, Are You Ready? With the idea of really exploring how pediatric readiness can improve quality of care for children with traumatic injury. All right. Dr. Jensen, thanks for joining.
Of course. In addition to all that stuff, I just love taking care of kids and talking about trauma and teaching about trauma and hopefully answering some questions. I am presenting from my laptop today, which is one small screen, so I might not see the chat. So if you have a burning question, I give everybody on the call permission to just interrupt. So come off mute, say, Dr. Jensen, I'm happy to pause and answer questions in real time.
So Dr. Jensen, I'll be monitoring the chat, and by all means, they can use the chat for the questions, and then I could pop them back to you.
That sounds great. All right, cool. All right. Sounds good. All right, let's get started. So I don't have any formal financial disclosures. I do get some salary support from the AIC and the Pediatric Pandemic Network to do things just like this today, and to work on trauma systems and trauma preparedness. And I'm also actively involved in the National Pediatric Readiness Project. Here are the goals for today. I think most importantly for centers that don't have surgical capabilities for kids, if you walk away with one thing today, it's that the most important thing is to recognize a child that exceeds your center's capabilities and to initiate the transfer process early. That doesn't mean transfer them early necessarily, but at least get in contact with the pediatric trauma center and start to get some guidance and make some shared decision-making about imaging and so forth and so on. But recognizing hemorrhagic shock, recognizing severe TBI is very important. I'm going to do a little work talking today about massive transfusion in children. Believe it or not, there are pediatric massive transfusion protocols, and if you apply adult protocols to very small children, you will end up with an unbalanced transfusion, and outcomes for those kids are not as good. So I will give you a pediatric MTP today, or at least show you where to find one. We'll talk about triggers for activation of MTP, and then talk about identification and early management of severe TBI in order to implement neuroprotective measures. So I know there's a lot of text on this, but most of my slides will have lots of pictures, but this is what we hope to achieve. I recognize that some people may have to leave early. So this is one slide that has all of the important things that we will talk about. Okay, we already talked about the importance of early activation of the transport system for kids that need to be transferred out. I will show a little bit about time is brain. I know the stroke community has a corner on that particular catchphrase, but it also applies to severe TBI. A brain under pressure that needs surgical decompression is a brain that has ongoing ischemia, right, which is the same as stroke. So the quicker you can get them to decompression, the better. Hypotension is late. Don't wait for it. We'll talk a lot about that. Balanced massive transfusion in kids is important. We'll talk about that and give you some tools for how you can implement that in your center in case you ever have to do that. There's a lot of confusion about what it means to transfuse a kid and what you should expect. For all of us grown adult humans, if we give 1 unit of packed red blood cells, we would expect all of our hemoglobins to go up by 1 gram per deciliter. In a small child, every 5 cc's per kilo will give you a 1 gram increase, right? So oftentimes we will see small kids get a unit of blood. But in reality, a unit in a 10-kilo kid is 30 cc's per kilo. That would be like giving you or I 6 units of blood. So understanding response to transfusion and expected response is important. I promise you that if you don't have a pediatric MTP, you will end up with unbalanced transfusions if you apply adult massive transfusion protocols. And finally, we'll talk a lot about decision-making in real time. You don't have a lot of time to make these decisions. Relying upon your memory under high-stress situations generally doesn't end well. So I'd like to talk about preparedness for having resources that can be used just in time to refer to so that you can make decisions about medication dosing, E2 tube sizes, so forth and so on. And at the end, we'll talk about imaging. And I would just say if you don't have capabilities to fix injuries, don't go looking for them with imaging. Really use imaging for kids that you think might be able to go home from your ED when it's indicated. So that's the keys. Let's go into some detail. So before we start, I think it's important to understand that for pediatric trauma, the same principles apply. Airway, breathing, circulation, disability. These are ATLS principles, and C is not CT scan, which often seems to be the case. But make sure that you support the airway if necessary, support breathing, support circulation, which includes stopping the bleeding. Okay, that often gets overlooked. We can give a lot of blood, but really getting hemorrhage control is important. And that might require early transfer out to a center with surgical capabilities. And then finally, disability, which gets back to the time is brain moniker. ATLS is often called an adult course. And I would just like to remind everybody that ATLS applies to kids the same way that it applies to adults. There are a few modifications that are related to tube sizes and weight-based dosing of medications and transfusion, but the principles of ATLS still apply. So you should be treating these injured children just like injured adults with some minor changes and modifications based on their smaller sizes and some differences in their physiology, and we'll go through that a little bit. Okay, so all of this is going to be case-based today, and I do have some polling questions that are going to pop up, so get your mouses ready. David's going to help us get some polling moving. So we'll start with the case of an 11-year-old boy who decided to skip school and go play video games at his friend's house. I promise they were not playing Pac-Man or Super Mario. They were probably playing Call of Duty or Grand Theft Auto or something that got them a little bit angry with each other. The 11-year-old decided he had had enough and decided to leave and was stabbed multiple times by his friend's brother, 11 times to be specific. And he is brought to your emergency department by private car. Think about your own emergency department and your resources. And sort of, this could happen to any of us, right? Brought by private car to the closest hospital. So in triage is noted to be pale, cool, and diaphoretic. Mom says there's a lot of blood on the floor at home when she found them. His heart rate's 156. Blood pressure is 133 over 113. His pulses are very thready. So our first poll question, is he likely to be bleeding significantly, yes or no? Doesn't see, are people able to answer? I don't know, David, if you're able to see if people are able to.
They are answering, yes. And then when I end the poll,
I have to
we'll
answer
display.
too. Oh, I get to answer my own questions. Sweet.
You bet.
All right, cool. All right, let's pull up the results. Yeah. Yes, and I have no idea. Perfect. All right, but nobody said no. All right, cool. Let's see if I can. I lost control of the slides. Here we go. Okay. So yes, he probably is likely bleeding. We'll get into that. So his initial ED evaluation, so that the numbers I gave you before were triage. Now he's in your resuscitation bay. Heart rate's 150, blood pressure 130 over 90. His GCS is now 14, so he's got altered mental status with no head trauma. He gets an IV and a liter of saline given. There's no active external bleeding. What should we do next? So let's pop up that next poll question. Send him off to CT, intubate him, assess airway, breathing, and circulation, administer some 3% saline. I have no idea. And you can pop the results off when most people have answered. All right, ATLS principles. And I have no idea. Great. So some people are here to learn today. I love it. Yeah, so I don't think you want to go straight to intubation in this kid because he doesn't clearly have an airway problem. He may develop an airway problem, but assessing his airway and really supporting breathing and circulation and moving forward algorithmically is what we should do in this particular patient. The other thing I'd like to have you guys ask yourselves right now, is this 11-year-old kid with multiple stab wounds and shock staying at your center? I don't know, do we have a poll for this one? Yeah, I think so, yeah. So who's gonna take care, if you're gonna provide definitive care for this kid, click yes. If you're gonna send him out, click no. 50-50, okay, cool. So I think this is a great mixed audience. So I would say that many of you guys may be coming from centers that are going to be accepting these patients from referral hospitals, and many of you are at centers that are going to be sending them out. So I think one of the keys here is a regional approach to pediatric injury and trauma care and having regional collaboration between centers. So I'm really happy that we have a nice mix of people on the call today. So at my center, I would take care of this kid. There are many centers that would stabilize and transfer out. So this particular patient was treated at a center that had surgical capabilities. They were not a pediatric trauma center, but they did have surgical capability. In the trauma bay, his airway was intact. He was treated with oxygen to start. Diminished breath sounds on the left. You can see his GCS there. Blood pressure, systolic's a little lower. His diastolic is still quite high at 90. His heart rate is a little bit better. He got some saline at this point. And is responding to resuscitation a little bit. He's quite tachypnic. Sats are okay on a non-rebreather. Initial hematocrit is 31. No active external bleeding. Abdominal exam is positive. FAST is positive, but most importantly, the pericardial view is negative, right? So any stab wound to the chest, you want to be looking at the pericardium, because if they have significant pericardial tamponade and you intubate them, they can go into an immediate arrest, and those patients may need to have their pericardium decompressed first. But fortunately, it was negative. Chest x-ray was clear. Remarkably, there wasn't a lot of blood in his chest. He had a left chest tube placed. So next question, what size ET tube does he need to have? 5.0, 6.0, cuffed, uncuffed? I have no idea. 11-year-old, 50 kilos. All right, what do we got? That's what I was hoping for. I have no idea. So I, Aaron Jensen, actually clicked the box that said I have no idea. And I really want to emphasize here that I personally don't even rely on my memory or math in real-time scenarios in order to calculate these things. We have resources in our trauma bay at a pediatric trauma center that has all of this stuff listed out. Okay, so I'll talk a little bit about those resources here. So it's really important for kids, particularly if you don't take care of kids often, to have standard equipment and to have standard reference guides to tell you what size tubes to use. I will say that in trauma, we always use cuffed endotracheal tubes. Many of these kids have emesis. They've got full stomachs. You know, the CT scan always shows a big cheeseburger in the stomach. So their risk of aspiration is very high. So cuffed tubes in trauma should always be placed. But really, you should have a resuscitation cart that is organized by patient size and weight. Okay, everybody should be weighed in kilograms, or if they're too unstable to be weighed, then you can just estimate their weight based on their length. Okay, with a Broslow or significant tape. A similar tape. Recognizing vital signs in kids, abnormal vital signs, is very hard. I would recommend that if you don't take care of kids often, that you have a chart on the wall of your resuscitation bay, or flip cards, or you refer to the Broslow guide in your resuscitation cart, but have a way to objectively quickly look at what is normal for different ages of kids. And finally, have pre-specified medication doses, because medication dosing errors in high stakes scenarios are more common than you might think. Everybody's stressed out, they do math poorly. So just have something. This is a resuscitation dosing guide. You can even buy commercial sets that have everything all pre-drawn up and measured for you. But all emergency drugs, and this here is coded by Broslow color and by weight. So you don't have to do math, you just draw up exactly what the chart says. So being prepared so you don't have to think in real time, I think is best practice for kids. In my pediatric trauma center, we have a binder on the top of our resuscitation cart, and each page has a different set of tube sizes and emergency medication dosing, even in a pediatric trauma center. Where we do this all the time. So we're not relying on our brains, we're relying on objective just-in-time resources. Sorry, there's a little bit of delay in the advance here, sorry. Here are some examples of some resources that can be used. Again, these are cuffed endotracheal tube sizes for different ages. And remember, not all 4-year-olds are the same size. Some of them are really small, some of them are a little bit bigger. Sometimes we just use the length-based tape if they look a little bit small for age to get a more estimated size and use the tubes for those. You can use this old mathematic formula, but understand that that's for uncuffed tubes. So if you have this formula committed to memory and you use it all the time, just remember you have to go down half size to put a cuff tube in. Okay, so he's intubated. I'm going to skip this poll because I think we went through chest tube sizes pretty well. Sorry, David. The chest tubes are on the bottom of this. This is another way to organize your equipment by Broslow color or weight color or weight category. Okay, so I don't think anybody ever needs a 40 French chest tube. I think 32 is fine for everybody. So I tend to use the smaller tubes on these ranges. But the point here is have a resource in your trauma bay that tells you what size tubes to put in kids if you don't do this often. Okay, so the question is same patient, is he in shock? We already said he's bleeding, and is he in shock or not? And what should we do next? Let's pop this poll up. He's had 1 liter of normal saline already. His hematocrit is 31. What should we do next for this kid? All right, let's see what the results show. Is the poll result stuck, David?
I don't know if we lost David for a second.
No,
here. Okay.
I'm here.
Okay.
You're not seeing the poll results?
No.
No.
That's okay. We can move along. This is a patient who is in most likely hemorrhagic shock. We could get a little bit more data to prove that. But I would say that any additional fluids after that 120 per kilo normal saline really should be blood products in this kid. Okay, so this is what I really wanted to get to. So I know it says on the bottom available today. It might be available later today, but hasn't posted yet on the website. So I worked with the EMSC Innovation Improvement Center, and we have created a toolkit for pediatric trauma resuscitation. And this is one of the just-in-time guides. This is for hemorrhagic shock. This is not the final version. There were some minor changes that were made, so don't download the one off my slides. These really should be available at that website listed on the slide either later today or tomorrow. But this is a hemorrhagic shock management treatment algorithm. Okay, and I'm going to go through a little bit of this as we go. But really what it says, and we'll talk about recognizing massive hemorrhage. But once you recognize, initial treatment really should be, large IVs, stop the bleeding if you can, and then early blood product administration. So 10 cc's per kilo, which again would be like giving you or I a 2-unit transfusion of red blood cells. We really try to limit crystalloid administration in kids that are bleeding because it doesn't really seem to help, and the outcomes have shown that if you have early blood product administration in kids who are bleeding, they tend to do better. Most importantly, kids get cold really quickly. So try to remove any wet clothing, try to cover them up, use your bear hugger, use any warming devices that you might have. But most importantly, all the blood that's going in really should be warmed if at all possible. We also had, normal vitals on the back page of that. Okay, so that kid was in shock. This is his initial blood casts, pH of 6.9 with a base deficit of -20 and a lactate over 15. His hematocrit's now down to 27. Okay. Remember, hematocrit takes some time to equilibrate. So he's bleeding whole blood. So his hematocrit is 27, but he's probably lost a ton of blood. Okay, he's already developing coagulopathy associated with trauma, and he has hyperfibrinolysis and is chewing through fibrinogen. And we'll talk a little bit more about that when we get to massive transfusion practices. So before these labs even came back, these labs take time to cook up, right? He had already gotten 3 units of red cells and 1 FFP and 1 platelet at this center because they did not wait for the labs to come back to start giving blood products. So kids who you have a high suspicion of bleeding that are in shock, please move early to administration of blood products. So this particular patient went to the operating room, had an XLAP, had some bleeding from his liver, which was controlled with packing. He then had a right thoracotomy, and he didn't have a hemothorax because most of the blood was coming out of one of the chest wounds. He had an injury to his intercostal artery, which was the source of most of his hemorrhage. So the hemothorax was evacuated. He had a lung resection, repair of diaphragmatic hernia injury, and most importantly, ligation of that intercostal artery that had been severed by the knife. He had a great outcome. And the massive transfusion protocol at this particular center, which was pediatric specific, resulted in post-op coags all being normal despite him getting 150 cc's per kilo. This is a lot of blood. This is 1.5 to 2 blood volumes in a kid this size. So he had a lot of bleeding, but a very balanced transfusion and normal coags post-op. I'll point out that this kid who had lost this much blood, who was in severe hemorrhagic shock in the ED with a pH of 6.9 and a lactate over 15, always had normal blood pressures, okay, at least from a systolic standpoint. I will point out the diastolic blood pressures here, 90, 90, 113, these are all very, very high. And this is the physiologic response to hemorrhagic shock. So as a trauma surgeon, when I see a kid who's profoundly tachycardic with a very high diastolic blood pressure, I look at that kid and I say, he's in compensated shock and he's getting ready to decompensate, okay? So the problem with shock recognition in kids is that they can compensate and they can compensate tremendously, and they tend to not be hypotensive until it's very late in their course. These are my 2 cute little kids. They're a little older now. This photo was taken about 4 years ago. Exactly, narrowing pulse pressure. So they're super cute until they're not, right? So kids cry. And when kids cry, their heart goes up. Their heart rate goes way up when they're all mad. And when we're poking them with needles and doing all kinds of stuff to them, they cry. It hurts. They're scared. Sorry, this advancement's a little bit slow. They have pain. Okay, they bleed, right? And that's what we don't want to miss. So oftentimes the tachycardia gets chalked up to all of these other things where kids are crying, they're scared, they have pain. And they say, well, and kids just have a little bit higher heart rates, okay? But recognizing shock in kids, even in the presence of tachycardia, is important, okay? It's also important to know that kids, more often than not, after blunt trauma, also have an associated TBI. And the physiologic response to intracranial hypertension is to drop your heart rate and increase your blood pressure, right? Which is opposite to what you have if you're bleeding. So if you have a patient with a severe TBI and hemorrhagic shock, their vital signs can often look somewhat normal. So how do we sort through all of this stuff? It's a little bit challenging. Our goal is to preserve cerebral perfusion for all of these kids, increase cardiac output. Can you comment on shock index? A little bit, yeah. And our goal is to really maintain SVR. So, yeah. One of the things that we really rely on kids is physical exam findings. Okay, so the patient that I presented that had been stabbed multiple times had very poor peripheral perfusion. He had very slow capillary refill. That's how kids compensate. So this is a photo of a kid who has cyanosis from cardiac disease, not from hemorrhage. Generally, kids who are in hemorrhagic shock with blue toes and fingers, we don't take time to take pictures. But this is very similar to what you see. You'll see impaired capillary refill. You'll see tachycardia, poor peripheral pulses, but most importantly, when you start to see mental status changes like this kid had, you have to worry that they're in class 4 shock. So if we can't rely on vital signs, and Dr. Gaucher-Hill talked a little bit about shock index, there is a pediatric adjusted shock index. It does work, but it requires doing math. There are some apps that can be used, and it has been shown to be useful to recognize shock in kids. But it just, the pediatric adjusted shock index has been around for over a decade, and it just really hasn't gained traction in ERs. And I think mostly it's because the abnormal values have to be adjusted for age. Younger kids have higher values than older kids and adults. So the SIPA, or the shock index pediatric adjusted, does work. If it's something that you want to use in real time, I would suggest getting an app on your phone that you can put in the numbers, and it will give you the results and also the interpretation based on age. So shock index does help, but it is also reliant upon vital signs, right? So you have to look at those vital signs, and tachycardia, as we just talked about, can vary. So how do we activate massive transfusion protocol? How do we recognize severe hemorrhage? So vital signs are going to be part of it. Mechanism is going to be part of it. This kid had multiple stab wounds to his chest and abdomen, so there's a very high probability he has hemorrhage. Imaging findings, particularly FAST, we can use FAST to localize severe hemorrhage. And in the patient we presented, he had a clear chest x-ray and a positive exam on his abdomen, so that's why the surgeons decided to go into the abdomen first. And then we can also incorporate labs, understanding that those labs take some time to get back, although in most centers, you can get a blood gas back in a few minutes now. Okay, so the bottom part of that EIIC hemorrhagic shock management resuscitation algorithm includes the ABCD score. Okay, so the ABCD score looks at these 5 factors: penetrating injury, positive FAST exam, tachycardia, or hypotension. This also could be an abnormal shock index, as Dr. Gaucher-Hill brought up. Any venous lactate greater than 3.5, or venous base deficit worse than 8.8. Okay, so you get a point for each of these if you have them. If you have more than 2, you are at a greater than 50% chance of needing a massive transfusion protocol, and you should activate. If you've given more than 20 cc per kilo of red blood cells, and they have ongoing instability, that patient has a very high probability of needing a massive transfusion, and you should activate for that as well. Activate for active visible bleeding that can't easily be controlled. These are some very, very high yield specific things that you can activate an MTP for to get balanced resuscitation for these patients. But most importantly, you should also focus on controlling the bleeding. And if that requires a transfer out, then work on that right away so that you don't have any delay to hemorrhage control. Here's the ABCD score if you want to read the paper. It's based on these things. This is a cohort of 210 kids, 66 were massively transfused. And here is the sensitivity and specificity. So this is the number of factors. So if you have 2 factors, you have a 52% probability of needing an MTP. If you have 3 ABCD points, it's 78%. So this scoring system really does work. And it does rely on a blood gas, right? So don't be afraid to get a blood gas in a kid, because it gives you a lot of information. Okay, if you have a kid who's tachycardic and has acidosis, you have a problem, and you probably need to either get that patient to a hemorrhage control, and you need to initiate blood product-based resuscitation. Yes, these are from these values that I put down are from a venous blood gas, so it does not have to be arterial. All right, so balanced resuscitation in kids. I think many people have seen this. You get coagulopathy just from the injury in and of itself. So when humans are injured, the response is often hyperfibrinolysis, so you have breakdown of clot, and a hypocoagulable state, particularly with traumatic brain injury. But then the doctors and nurses get involved, and we give them resuscitation-associated coagulopathy because we give a bunch of red blood cells, but we don't give factors with them, and we dilute out the intrinsic clotting system. The body's also consuming factors, trying to make clot, trying to stop the bleeding with its own homeostatic systems. So that uses them up as well. And then you get some acidosis and you get some hypothermia, both of which are bad for the clotting cascade. And it then becomes a vicious cycle of coagulopathy, acidosis, and hypothermia. So if you're cold, you don't clot, so your coagulopathy gets worse, which means you bleed more, which means you're more acidotic. And then you get cold because you're giving cold products. So this particular triangle, if you don't interrupt this, it will always lead to death. So this is why we initiate early balanced blood product resuscitation in bleeding trauma patients early. You've probably heard this in adults. It applies the same to kids. Here's some data that shows that. This is a retrospective multi-center study that compared massive transfusion kids who had 1-to-1. This is what we really want. So low ratios. So every unit of red cells to a unit of FFP. And this is mortality. And this is 3 units of red cells per every 1 unit of FFP. Mortality was a lot higher in this particular group. Another study looking at a protocol implementation. This is pre-post implementation. Sorry, this isn't showing up very well on my screen. 1-to-1, and 26 kids pre and 17 post. Most of them ended up dying from TBI. Who knows if the TBI got worse because of the coagulopathy, but pre-implementation, they had 4 out of 26 died, and afterwards 0 out of 17. Very small numbers. This was a pilot study for an ongoing multi-center trial for resuscitation ratios. But the data does suggest that kids behave just like adults, and trying to achieve 1-to-1 RBC to FFP ratios in hemorrhagic shock is probably important. Okay, so here, also included in the EIIC resources that hopefully will be released either today or tomorrow at the website below, is a pediatric massive transfusion protocol. Again, this is just a draft. The new one actually includes packs 3 and 4 for each of these groups. But I would encourage everybody to download this. If you don't have a pediatric massive transfusion protocol, I would recommend that you get one. You can use this one online. Because if you don't use pediatric weight adjusted ratios, you will over transfuse with red cells and make that dilutional coagulopathy worse. Okay, so we've tried to make this standardized and easy for you guys to use. If you are at a pediatric center that has your own already, I would encourage you to look at this resource and use it with your referring regional hospitals as a communication tool. And you can point them to the website. And this really improves communication between centers around how to do that initial resuscitation while they're waiting for the aircraft to arrive. So this tool is just as important for pediatric trauma centers to use for outreach and education as it is for centers that don't take care of kids very often. All right, so we're going to switch a little bit into another case. So a 7-year-old boy flew off. He was riding this thing. It's called the wave ray that spins you around really fast. His safety bar let go and he flew off the side of this thing, and he flew a long way, about 40 to 50 feet in the air, into a light pole. Unfortunately, sustained some significant head trauma. GCS on scene was 3. The carnival that he was at was literally across the street from an adult trauma center. So EMS brought him across the street into an adult trauma center with a GCSF3, and they had to give him some epi en route for blood pressure of 60/45. Is this hemorrhagic shock, or is this shock all from TBI? Let's try the polls again, David. 7-year-old flew off. I'm not seeing the poll on my screen.
I apologize. I don't know why they're not running. I've clicked the button.
Not showing up.
Yeah.
Okay.
No,
Marianne,
I don't see it
just not-
either.
You don't see
Yeah,
it either? Okay.
no, I don't see it.
All right, well, just ask yourself, ponder this question. 7-year-old, severe head trauma, very hypotensive, requiring epinephrine. Is he bleeding, or is this just his head? And the options were, yes, he's bleeding, no, he's not bleeding, this is mixed shock. Or the final answer on the poll was, I don't care and it doesn't matter, which is actually the right answer. Okay, so we don't quite know why. I'd ask you, and I would suspect that this is probably the same as the early poll. Is this kid staying at your center? And if not, we should activate transport resources now. Okay. It's possible this kid might stay at your center for a craniotomy because your neurosurgeons may be willing to look in his head and decompress anything, but you might not have a PICU. So you might need to transfer him out post-op to a PICU. So either way, if he's going to be transferred out from your ED, or if he goes to the operating room in the ICU, I would encourage early communication with the pediatric trauma center so that transport assets can be mobilized and get this kid there. Oh, the poll just finally showed up.
I'm clicking behind the scenes. Trying to fix it.
All right, cool. So what do we do next in this kid? Let's try the poll again. Let's see if it pops up.
It's
all right. Okay, so kids get head injuries, and they're going to show up at your center. I think with head injuries, the real goal is to prevent secondary injury. And the way that you prevent secondary injury is to avoid hypoxemia, avoid hypotension, avoid hypoglycemia, and I would also add avoid seizures, because seizures Here we go. Is he staying at your center, and what do we do next? Let's see if people can answer these two together. Give some mannitol, send him off to CT, transfer him out right now after the EMS just pushed some epi. All right, any results? Okay, we'll wait for the results to pop up. So really preventing seizures and preventing hypoxia, preventing hypotension. Oh, I lost my screen.
Just here, let's try this. Can you see the results? I had
Yep.
to switch to a different method.
Okay. Let's go to the next. The next question is probably more important. Those look pretty similar. So what should we do next? Resuscitate for ATLS, right? I'm happy that nobody gave mannitol and that nobody sent this kid out from their center immediately without an airway and without getting some blood. Okay, cool.
Going back to your.
Awesome. Okay, cool. So I would argue that any receiving center should be able to get an endotracheal tube in, should be able to give blood products for resuscitation, should be able to give 3% if they have signs of intracranial hypertension, and should be able to give Keppra to prevent any seizures from occurring if they're going to be, going off the OR transporting. So these are the tenets of severe TBI resuscitation. The Brain Trauma Foundation does say that they prefer 3% over mannitol. For those not used to taking care of kids, mannitol is very potent and it's an osmotic diuretic, and it will make kids quite hypovolemic. And then they're hypotensive, and then they get secondary brain injury. So we don't recommend mannitol until patients are well resuscitated and you ruled out hemorrhage. So the first line therapy in the trauma base should be 3%. Here are those Brain Trauma Foundation guidelines if you'd like to refer to them. But more importantly, this is a draft of the new EIIC TBI resuscitation protocol. Okay, you can say, ATLS principles, initial treatment, protect that C-spine, indications for endotracheal intubation. Remember, a drop-off of 2 points in the GCS or a GCS less than 8, you should intubate. And then consider 3%, and then Keppra and sedation if you need to control their ICPs. Okay, and then the branch point between do you have neurosurgery or not neurosurgery. The most important part is if you don't have a neurosurgeon in your facility, do not delay transfer out to obtain a head CT, okay? If you are waiting for the transfer asset, call the pediatric trauma center, and if they say yes, get the CT en route, then go for it, but make sure that that's done in collaboration with one of your regional centers. A little bit about kids, they have a little big bowling ball on top of a little body. So TBI is very, very common in kids. C-spine ligamentous injury is very common. Chest injury without rib fracture is very common, and their belly is just poorly protected, so they tend to get solid organ injuries. Kids get cold really quickly. Their skin is very thin, so you have to work really hard to keep them warm. They decompensate very quickly because they have a small functional residual capacity. So when you intubate, they're going to desat very quickly. And we talked about compensatory mechanisms for their vital signs earlier. Pediatric GCS, I even have a hard time calculating this on a regular basis. I have this particular rubric on my wall, okay, because most 1-year-olds don't talk, and my 4-year-old doesn't follow commands. So just have a resource to calculate a GCS in young kids. So this patient presented to an adult trauma center, was a full activation. You can see the vital signs there, very tachycardic. He got intubated in the trauma bay, chest x-ray, had some rib fractures, but no hemothorax. FAST was positive. You can see he has a base deficit of 15 and a lactate of 7. The next poll question is, should we activate MTP? Okay, yes or no? Or yes, but more importantly, make plans for hemorrhage control. All right. So I think we definitely should activate it and make plans for hemorrhage control. I think in this particular patient with a positive FAST is very important. Cool. So everybody already knows this. That's awesome. So this particular patient luckily presented to an adult trauma center that had a very strong relationship with the pediatric trauma center. They actually called the peds trauma center as soon as the patient arrived, and the aircraft was put in the air, and they said, look, we'll be there in 30 minutes. This particular center was not going to keep a patient locally. So now you're sort of having to deal with resuscitation versus definitive care. There was some shared decision-making that because you've got 30 minutes and this patient had responded to initial resuscitation to get imaging, this particular adult trauma center had digital imaging transfer protocols so that the patient's in the aircraft flying and the images are already at the receiving center so that they can make plans to get that patient directly to the operating room after looking at the head CT or get them into the ICU quickly. So there is a role for imaging at the initial receiving center, but only if it's not going to delay transport and in consultation with the receiving center to make sure the appropriate images are obtained. This patient had a great outcome. He did have a head CT locally, had some shear injury. This was not a surgical lesion. He had a spleen lac that stopped bleeding by the time the kid got to the trauma center. He did get massively transfused. The massive transfusion protocol was activated at the initial center. And this kid had a great outcome. He was transferred to the rehab center at the pediatric center. And this went well because that initial receiving adult trauma center had pediatric facility recognition for pediatric readiness. They had resuscitation protocols in place, all of those guides that we talked about. They had a pediatric MTP. And even though his initial hematocrit was 32, he did have significant hemorrhage, and they transfused him 2 units of red cells before the helicopter had even arrived. And I think the most important thing is shared decision-making and early activation of the transport system and optimizing the care for this particular kid. This adult trauma center has the access center phone number on the wall in their trauma base so that they know how to get a hold of a pediatric trauma surgeon as quickly as possible, and they can get guidance on whether or not to go off to CT or not. And again, patient had a great outcome. All right, I'm just going to do a quick time check here. Oh, we're perfect. All right, so the last 5 minutes, and we'll save some time for Q&A. Last 5 minutes, I'm going to talk a little bit about imaging. Okay, so this is, I don't know if anybody's familiar with Rock and Jump. Actually, I think they've been bought out now by another company. They've changed their name. But this is an indoor trampoline park where kids go to sustain injuries. We see lots of kids here, but it's lots of fun. And believe it or not, I actually let my children play here. So a 3-year-old was at Rock and Jump and actually fell off the back of one of these apparatuses. So they had climbed all the way up on top. They were standing up and somehow slipped behind the fence and fell off. These things are elevated about 4 to 5 feet off the ground. And it was estimated that this kid fell 20 feet onto concrete. Okay. Dad went down after her. Dad was fine. And he says that she did not have loss of consciousness and cried right away. Comes into your ED, heart rate's 138, respirations are fine on room air, GCS is 15. She's got some bruising to her head and face. Head's a little bit boggy and a little bit tender. And there's a little abrasion on her right costal margin, but her abdomen is soft, non-tender, and non-distended. The rest of her exam is normal. So question is what, actually the whole question shows up on one more slide, hold on. This is a high mechanism, normal vitals, except some tachycardia, and she is crying, and some abnormal findings on the head. So what imaging should we get next? Let's pop that poll question up. Plain x-rays, start with an ultrasound, or go straight to CT, or maybe just rely on clinical decision-making and don't do any imaging on this child. I'm actually really interested to see what the polls say on this one, because there's a lot of variability in practice here. Okay, so a lot of places are saying straight to CT. Okay, some people say start with ultrasound, some say start with x-rays, and looks like a few people said no imaging, discharge based on clinical findings. Okay, so high mechanism trauma, so 20-foot fall is a big mechanism for a kid. And I would say most of the group is saying go straight to CT. And I'm not surprised by that. So she arrived to the ED at 21:25 and was off to CT 35 minutes later for a pan scan. Did not get a chest x-ray, did not get a C-spine x-ray, and was waiting on labs. So I say this kid hit the jackpot. They get the $1 million workup with a whole body CT. Why this might be a good idea, maybe why not. So high risk mechanism, I think many people are familiar with this. 2 to 3 times body height in the kid, MVC criteria. These are pretty well publicized. I would say that all the things I'm about to say on the next few slides do not apply to kids who are suspected of having child abuse. Okay, so all the rules go out the window about who should get imaged. If you suspect child abuse, you really should consult with a center that is experienced in working up child abuse. So all of the next slides are gonna deal more with kids who are victims of accidental trauma. So benefits of routine whole body CT based on high risk mechanism have been very clearly demonstrated. These are the two level 1 trauma centers in my region that take care of adults, and they pan scan everybody that has a high risk mechanism. And I think that is the right thing to do because there are benefits to routine whole body CT, particularly in adults. Faster time to diagnosis of all injuries, but also fewer missed injuries. Understand that adults have a lot of radiographic baggage. You know, if you've seen an x-ray of my neck, you wouldn't be able to tell if it's chronic or if it was from an injury that I had, right? So all of us that have a few years under our belts have abnormal imaging at baseline, and it can be hard to tell if it's from the injury or if it's chronic. So CT misses a lot fewer injuries in adults. But kids don't have that. They have pristine anatomy on x-rays, and most of the time you can tell if they have an injury based on x-rays alone. The downside of routine whole body CT is the radiation. There used to be a lot of sort of funny math on radiation exposures from Chernobyl, and they calculated estimated malignancy rates. But this is actually real world data. So this study was done in Korea, and they have a centralized healthcare system. So they have records on everybody. And they know who had, this is a cohort of patients who had appendectomy. And if your appendicitis was diagnosed with CT, as opposed to no CT, just ultrasound, they were able to follow you over time to see who actually got malignancies. And they looked at hematologic malignancy within 2 years and abdominal pelvic solid organ injury, solid organ cancers after 5 years. And they found that in patients that were in the CT exposed group, that they had a higher risk of hematologic and abdominal imaging. So 25% increase in developing leukemia in these kids. So it does induce malignancy in kids, and we really should try not to CT kids if it's not necessary. Now, if a kid needs a CT, they need a CT, but there have been protocols developed to minimize body region specific CT in kids. So the routine whole body CT for mechanism alone can be cut down as long as the kid is hemodynamically stable. We did a 5-center review in Northern California of all of the patients that were transferred into the 5 pediatric trauma centers. And we found that 83, and we used the TQIP best practice guidelines for imaging as to who should get what body region CT'd. 400 kids over 2 years, 83% of the whole body CTs that were obtained did not meet indications for the TQIP best practice guidelines. So there were a lot of scans done in kids who didn't need scans. And in this cohort, 75% of kids actually had no indication for any CT whatsoever in any body region, and they got a whole body CT. You can see that most of the CTs that were not indicated were chest CTs, also neck, and then some abdomen and pelvis and some head. So who should get a whole body CT? So in pediatric trauma, we don't routinely do whole body CT for mechanism. You should do whole body CT with patients with high risk mechanism and severe neurotrauma, so GCS of 13 or less, and they don't have a reliable exam, and you think that this kid's going to end up in the operating room quickly with the neurosurgeon, and you need to quickly rule out any other imaging. But in a hemodynamically normal patient with a GCS of 15 and a reliable exam, you have time, and you have time to rely on your physical exam, perhaps get some blood tests, perhaps get some plain films, and maybe cut down on some of the body regions that are going to need to be CT'd. So if we look at the various body regions, this is the EISC best practice guidelines for pediatric imaging, and this is for cross-sectional imaging. You can see a couple of them I put up here are blunt abdominal trauma and then blunt thoracic trauma. So who needs a belly CT? Who needs a chest CT? Most pediatric patients don't need a chest CT if they have a normal plain chest radiograph. Okay, so there's a 1-page algorithm for each body region. And again, these should all be available free for download either today or tomorrow at the EIC website. So in summary, recognize shock. Don't rely just on blood pressure. Get a blood gas. Look at acidosis. Learn that ABCD score. Perhaps put a little poster on your wall with the criteria. But if you've got an ABCD of 2 or greater, you should consider MTP activation. I'm stuck again. MTPs, remember, each 5 cc per kilo is similar to an adult unit. Okay, 1-to-1 ratios seem to be best. TXA, I didn't talk a lot about TXA in kids because it's becoming more controversial. But if you're within 3 hours of injury, feel free to give it. And the dosing is included in the EIC MTP algorithm. And please have a pediatric specific weight-based MTP that you should be able to download for free. Protect the brain, remain, normotension, normoxia, all of that stuff normal. Don't give mannitol. If you don't have neurosurgery and you have a severe TBI, don't delay to get a CT. That CT scan is not going to make them any better. It's just going to get a diagnosis. So if you can get them to a center with a neurosurgeon quickly, then do it without delay. Have a system to recognize abnormal vital signs, guide your tube sizes, medication dosing, and really rely on imaging guidelines. Don't delay transfer to obtain CT scans, and really use CT and clinical prediction algorithms to image kids that potentially could be stable kids who could be discharged from your emergency department. If they're going to be transferred out regardless, then I would have a discussion with the receiving center about whether or not you should do the CT locally or if it should be done at the pediatric center. So that's all I got. I was hoping to leave a few minutes at the end for questions. It looks like we have about 8 to 10 minutes left. Happy to take any questions.
Aaron, if I may, a couple things that I have taught to try to make it easy. You mentioned the Broslow tape for ET tube size.
Yep.
But you can also do something really simple. I could put it in the chat, but I do the infant and then 1, 5, and 10 rule. And so when you think about ET tube size, then that's 3, 4, 5, 6.
Sure.
Infant 1, 5, 10, 3, 4, 5, 6, and those are cuff tubes. In addition to that, the 1, 5, and 10 rule is 10, 20, 30 kilos, and you'll get in the zone. So I can put it in the chat. And I'm curious for chest tube sizes. I just multiply by 4. You get an approximate number. Also, it's on the Broslow tape, but 4 times ET tube size. So for 1-year-old, it'd be 16, 5-year-old, 20, 10-year-old, it's kind of, would be 24. Obviously, you may want, vary that, but I was just curious on the chest tube size. Is that something you use? Does that seem reasonable?
Marianne, you are much smarter than I am and much better than I am.
I don't know about better at math.
No, I just teach, don't rely on your brain. Don't rely on math. Because unless you do this regularly, you're not going to remember those formulas. I think if you do it regularly and you can remember those formulas, then that all sounds great. But I just rely on the quick guides that are just in time. They're either on my phone or they're in the binder on the resuscitation card or they're on the poster on the wall. I just find that if I can look at an objective resource, or the Broslow tape works as well, because I do think the Broslow tape has value. And I had a kid that I took care of. He was 4, but he was only 10 kilos. And EMS in the referring hospital didn't realize that he actually had a diagnosed growth restriction and was on human growth hormone at home. He was a really small 4-year-old. Yeah. But they used an ET tube the size of for a 4-year-old, the perfect size by doing math. But it was a really big ET tube, and he ended up getting subglottic stenosis and had to go to the OR with the ENT to get ballooned several times. So I do think the Broslow does have its benefits in terms of, not all kids are the size of their age. I mean, we've all taken care of, 10-year-olds that are massive, and we've taken care of 10-year-olds who aren't very big. I have 2 kids, and my 4-year-old is almost taller than my 8-year-old. They're just so different, right? So I think that unless you're really experienced with kids, I don't like doing math in my head. And I think that these sort of resources that can be objectively used are really helpful. But in a center like yours, where you see a lot of kids and you do it every day, then great. I think all of those formulas are fantastic.
Okay, thanks for that.
And I do think that the trauma community is really moving away from big chest tubes. There have been a number of studies that have come out in the last couple of years that are starting to suggest that even for hemothorax, a 14 French tube is probably fine. So I often put in tubes that are smaller than even the Broslow thing recommends. Most kids will be just fine with a 14 or a 16 French chest tube. Unless they're a teenager, they might need a 20, 24, something like that. But I definitely would not put a tube in any bigger than the Broslow tape says. And it's possible that you might even be able to treat the patient with a little bit smaller tube.
Really helpful.
Really, the thing I wanted to convey mostly today, guys, is that there are lots of resources available, and there's no substitute for preparedness. So we at the EIC have really tried our best to try to make these resources standardized and easily available and easy to follow in algorithmic format. So I would just, I really am sad that they were supposed to be online today at noon and they didn't. So, but hopefully, very soon you guys can download those, and those resources will grow every month. There will be additional resources added. And if there are things that you would like a standardized resource for that we don't have on the website, we are asking for feedback. You know, what resources do we need to develop next? What would be really helpful in your emergency room to help you guide resuscitation of you know, trauma patients? But you know, the whole EIC is all about kids in general. So if there are other kids that you would like, you know, medical conditions that you want resources for, we can share those with some of the other domains in the EIC. But specifically for trauma, if there's a resource that you think would be helpful for your center, let us know and we'll develop it. And we'll vet it with our stakeholders and make sure that it's accepted by everybody and put it out there. And for pediatric centers, I just ask that you download the resources and use them as a foundation for communication to your referral centers and try to get these pushed out so that people are using them. Other questions? I see a few things in the chat. Will those protocols be reviewed annually? I think they're going to be reviewed whenever new evidence comes out. You know, we had a C-spine algorithm all written, and then the PCARN C-spine paper was published, you know, last month. So we had to change that. So as new evidence comes out, they will be incorporated. The leadership of the EIC trauma domain, 3 of us are trauma medical directors at our own institutions, and we change our protocols based on best available evidence. So I would say that they're reviewed in real time as new evidence comes across. So hopefully, you know, at least annually, if not more frequently. And whenever there's a change, there will be something pushed out across the EMSC Pulse newsletter or across social media accounts so that we can keep you up to date. The MTP protocol will be available at the link that David put in the chat, hopefully today, maybe tomorrow, but sometime very soon.
And Pat had a question.
Yeah.
Pat Pross.
Yeah, more of a comment, but I'd like to know your opinion. Erin, fabulous presentation. You know, I mean, I really look forward to being able to share this, you know, on the Rapam YouTube as, you know, because this needs to be part of that push out. And if you can get it on the EIC website, I would highly recommend. I mean, this is exactly what people want to see in both the EMS and also the ED world and stuff. So kudos on that. But I know that Vicky Sakata is on this, and also Peter Antevi have really kind of have tried to demystify and in terms of, you know, this nomenclature about children are not little adults, but rather are little adults in some ways. And because we have created a culture of fear, you know, and we've done a really good job of really scaring the living daylights out of people. And this is the biggest barrier that we have in order to get adoption and engagement in these areas. What are your thoughts in working with the EIC in terms of reframing this? And Vicky, if you're on, you may want to step into this too.
Yeah, I mean, my thoughts on trauma are ATLS is an all human protocol. It doesn't matter your age. The principles hold true just the same for infants as they do for 80-year-olds. I do think there are special things that you have to pay attention to in 80-year-olds, particularly the fact that their blood pressure yesterday was probably 180, and if their blood pressure is now 110, they're probably hypotensive, right? So I think that even, you know, at the extremes of age, there are differences related to physiology, and particularly in kids, drug dosing and transfusion volumes. But the principles of ATLS, you know, hemorrhage control, supporting an airway, decompressing obstructive shock are the same, right? So kids' physiology is a little bit different, but they need to be supported the same way. And I think that any adult trauma provider should be able to take care of a kid for the first hour. They should be able to get an ET tube in. They should be able to place a chest tube. They should be able to transfuse. But they're probably going to need a little bit of just-in-time support with resuscitation guides, with drug dosing guides, with transfusion guides, all of these things, because people aren't used to dosing and sizing things in kids. But the principles of treatment are the same. You just need a little bit of support. I signed a disclosure that said I won't talk about any commercially available products. So for that reason, I haven't endorsed any commercially available products. But I will say, without endorsing any single company, I think it's a great idea to have a standardized system that tells you what type of drug to give at what dose and blah, blah, blah. So I'm a big fan.
Thank you. I think, I don't know if Vicky's still on. I think she jumped off, so we missed out on her input.
Cool. Other
Thanks,
questions?
Aaron, is it okay if people ask to share the PPRP results? Is it okay just to encourage people to talk to their agencies?
Yes, fine by me.
Just for those, just very briefly, the pre-hospital pediatric readiness survey is out to all EMS agencies in the US, and these are the results so far. We'd like to try to get everybody at 100%, of course, but we only have a few more days. And so those in the various states can reach out to their EMS for Children coordinator. They can also reach out locally to their EMS provider agencies to see if they have responded. And just a big plug to please encourage people to respond to the survey, because the more that respond, the more that we can help those who don't respond, and also be able to do some research related to pre-hospital pediatric readiness and pediatric outcome. So with that, I'll stop sharing. I hope everybody got to see what state they are. The large states are obviously challenged, but they're doing pretty well overall.
And I put the links in the chat to where they can bring that up, and also even drill down to their local level to see who's done it.
Perfect, David. Yeah, the way to do it is to go to your, I look like you're going to fill it out, go to your state and county, and then see who hasn't responded. It may just be at a state level as well. Thanks.
I dropped my email in the chat. If anybody has any other questions they'd like to ask offline, feel free to email me. I'm happy to discuss further. Thanks everybody for coming out today. We really appreciate the engagement. I think this is how we get the message out. This is how we share the resources. This is how we make care better for kids. So yeah, please share all of this stuff widely amongst your own networks and your own regions. See what we can do to raise the bar for kids all over the place. Cool.
Thank you, Dr. Jensen and Dr. Gashi Hill. And if you have suggestions for future topics, we're looking for them, and speakers to ask to present in the next quarter, please email Dr. Gashi Hill or myself, and we'll reach out to them.
Thanks, Aaron. This was really outstanding, honestly.
That's a lot of fun. Thanks for having me.
All right.
Yeah. Bye, guys.
Bye, everyone. Thanks, Dave, for coordinating, as always.
You bet.
All right. Bye-bye, all.